Dr. Turki is a consultant of genomics and bioinformatics at King Saud University. Dr. Turki currently leads the molecular genetic lab at King University and Anwa Lab. He leads multiple national screening program for genomics profiling of multiple cancer across the country. And without further ado, Dr. Turki is going to present us germline mutations versus somatic mutations. Dr. Saeed, the mic is yours.
Thank you very much, Dr. Al-Ahmari. Assalamu alaikum wa rahmatullah. Good evening, ladies and gentlemen. It's my great pleasure to be here today, and I would like to thank the organizer committee and Dr. Al-Isa for their kind invitation. Dr. Ahmari, can you confirm my slides are working?
Yes.
Perfect, thank you. So, the elegant talk by Dr. Jeffrey is a nice segue to what I will talk about, which basically how from the lab side we report deleterious germline variants in hematological disorders, some thoughts on it, what's the process look like, some caveats to share with you this very important component that is growing in the medical practice over the last few years. So just to be on the same page, this is 101 genetics, somatic versus germline. This talk is all about the inherited mutations from the parents that get passed to the germline cells, the gametes, sperms, ova, to the zygote, and then it will be copied in all of the cells in the embryo, and it will increase the predisposition to cancer, and the same mutation can pass to next generation. Unlike what we are all used to in hematological malignancies, the somatic mutation, which basically is not passed from upstream from the parents, but in fact is affecting a few cells in the body, usually caused by external factors in most cases, and it does not, they usually don't pass or transmit it to the next generation. So my talk is divided in three parts. Very quickly, we'll talk about the landscape of germline mutation and hematological disorders. Then what are the guidelines that is we use in reporting the pathogenicity of some of these mutations, especially those never seen before in the general population, and how can we be sure that we are classifying them in a systematic way. And finally, we'll see from the lab point of view, how does that fit into the workflow. So one of the largest studies that done in this area is this study from St. Jude Children's Research, a group in 2015, where they basically sequenced more than 1,000 patients younger than 20 years old. They used a combination of whole exome and or whole genome sequencing, and they focused on 500 genes related to cancer, with more than 60 genes of them being associated with autosomal dominant cancer predisposition syndromes. And they found that 1 in 12 or 8.5% of that cohort actually had a germline mutation in one of those gene of interest. When we look at the breakdown of this mutation, you will find that, and this is both solid tumors and hematological, leukemias and lymphoma represents almost 33% of the cohorts. So it's a big chunk of cancers that with the germline component. And if we say, let's zoom in a little bit, forget about solid tumors, let's focus on hematological malignancies. This is another study that showed when those patients, 67 of them, referred to hereditary hematological malignancy clinic, they found in 1 in 6 of them carry a germline predisposition to malignancies. So it is a big part. Germline is a big part, from 1 in 12 to 1 in 6. There is a growing evidence that it is more than what we think. Individually, they are rare, but together it's quite common. So when do we suspect a germline components in our patients? Of course, through the personal history and family history, we can suspect if there is multiple affected, multiple cancers. But I have to say that family history is not always positive. In fact, less than 45% of the patient will have a positive history. And this is especially true when we are dealing with autosomal recessive disorders where parents will be normal, but they are carriers, silent carriers. And when we are talking about the physical exam, this table will show you the wide spectrum of presentations associated with different genes. So in the left axis, the clinical features range between hematological findings to others in renal, cardiac, and other organs. And if we pick Elaine gene, for example, it's usually present with neutropenia and skin manifestation and affecting the growth. On the other hand, GATA2 is beside the hematological, it comes with immunodeficiency. But as you can see, the presentation can vary a lot between the genes. And if we are trying to see what are the clusters of these syndromes that Dr. Al-Jifri mentioned, some of them with the bone marrow failure, MDS, AML, and ALL, you will see, yes, bone marrow is associated with few of them, as well as lymphoma. But MDS and AML is usually appears in many of these syndromes. And if we want to discuss the mode of inheritance, autosomal dominance is there, X-linked is there, autosomal recessive is there. So it's a quite complex spectrum that could surprise us from different angles when we are dealing with the patient. So the question now becomes, if we are presented with a lot of genes, different presentation, what is the methods in the lab that we can use to test for germline mutation? Knowing that we are, we have more than 3 billion base pairs in the human genome. So do we do whole genome sequencing or we focus on specific genes? And what makes it a little bit more complicated is we are dealing with different biomarkers at the DNA level, from point mutations to insertion, deletions, large copy number variants, and then the structure variants with the gene fusion and translocation. And all of these require different methods, and not all methods are suitable for detecting these biomarkers. So in this slide, we are listing as a big, the large picture, the big picture, the different methods, that we use in the lab to detect some or all of these mutation. One of the most commonly used is the real-time PCR or the PCR-based assays, and it can detect point mutation and insertions and fusions, but it has to be well known. So it's not good when we are dealing with germline mutation because it's not a hotspot mutation. We don't know what we are dealing with. So PCR methods usually is not advisable in this scenario. FISH, on the other hand, is great for copy number variants and fusion, but it's not good for the smaller mutations or biomarkers. And if we are dealing with arrays, then copy number variants is probably the only thing that it can detect. So the golden standard usually is the capillary sequencing, which is the Sanger sequencing. It's an old method from 1970s, fantastic method, but it is very limited on the number of targets that we can use for. So naturally, in the last 5 years or so, next generation sequencing, which has the ability to detect theoretically all of these biomarkers, is usually the gold standard and the way to go, especially when we are dealing with multiple targets. As you saw with the Fanconi syndrome, 22 genes. If we are doing it with Sanger sequencing, it will cost probably 20,000-30,000 riyal, while with the NGS, it's a fraction of that, and it will cover most of the genes that we are interested in. So what is the tissue type that is suitable to confirm germline mutation? The blood, of course, is not a good source to confirm germline, given that the tumor cells is there, and we cannot distinguish germline from somatic from the blood. Buccal swab is widely used, but again, WBC's white blood cells can contaminates the buccal swabs. So it's not advisable, but can be used. Hair follicle is a much better sample, but it has the problem of being so small that it's required a very specialized lab to deal with a tiny number of cells where we can detect the germline mutation. So the most important tissue sample is the bunch biopsy or the skin biopsy, where basically we can use it, although it's a little bit invasive, to confirm the germline mutations. So the moment we are dealing with a mutation, a germline mutation, and we want to classify it and understand its pathogenicity, in order to make all the labs produce systematic, standardized way, 2015, there was a guidelines released by the College of American Pathologists and the Association for Molecular Pathology, where they listed a lot of protocol basically on how to approach it. I'm not going in any details of this. It's very extensive. I'm just showing a few things that we deal with. For example, they classify the evidence that support any mutation based on multiple axioms. In this case, if it is a truncating mutation, usually it's given a very strong evidence, but it's not alone. So we usually deal with multiple line of evidence. You see here each row represents one. For example, how frequent is this mutation in population? What does the computational and predictive data say about it? And in the third row, functional data that supports the pathogenicity. And accordingly, we weigh those evidence and give it as a benign or pathogenic. The right side, the pathogenicity can range from supporting, moderate, to strong and very strong. And just to give you one example of how we use population data to decide if this mutation is worth investigating as a pathogenic or not, we use multiple databases. One of the most commonly used one and the largest actually available is a free resource called Nomad. It's available online at the URL at the bottom. And it hosts more than 140,000 individual using whole exome or whole genome. So it's an unbelievably huge database from different populations, actually. And you see in this figure, how are those individuals clustered together based on their origin, from South Asians to Southern European, Swedish, Finnish, etc. And the word of caution here is Middle Eastern population is not well represented in this database, although there is some efforts into adding some of the population, especially from the Gulf countries, where they already have sequenced thousands of patients, into these publicly available resources. And if we are looking in one of those genes here, depicting the MPL gene, you see these curves that represents how well is the coverage at every exon. And if we are zooming in any of those exons, we will see a list of mutation. Each row represents one mutation with the classification that has been published before. And if we click on any of those mutation, we will have a breakdown and a zoom in and how common is that variance in different populations. Here is the allele counts. Here are the number of homozygous. So together, this paints an idea of a very rare mutation that does not appear in a lot of individual. So the rarer the mutation is, the more confident we are that it is actually lycopathogenic or pathogenic. And that's not the only evidence. As I mentioned, we use other resources, but it's a quite extensive process to evaluate every variance, making sure that it can explain the phenotype in the patient, because there's so many decisions that will be based on this. For one, it will provide diagnosis, to surveillance in the patients and the family, and later it will be very important when the time comes for donors to make sure that they don't carry the same mutation as the patients. So the last part is the workflow in the lab. And usually it's take place after doing the initial workup, from morphological assessments to the flow and immunophenotyping, cytogenetics, and fish, and the molecular studies. So if all of this is done, and this is one way of catching some of those patients, and assuming that we are doing a large panel for the hematological malignancies, some of those panels may have or include predisposition genes. And if we find a mutation there with a variant allele frequency of 30% or more, then this may indicate a germline mutation, and it warrants going through to get a skin biopsy. And from that, we can confirm it using a comprehensive germline testing. I need to focus on the VAF, the variant allele frequency, and explain what does that mean in this context. So there is a population frequency, and we assume it's very rare, but when we are sequencing the patient's DNA, we want to see a mutation with a higher frequency in his own DNA molecules. And if we are using next generation sequencing, it will give us tons, millions of short DNA segments that's actually required to be mapped to the genome. So in this picture, you see 5 random DNA fragments from that patient. And usually the first step is to take every read and try to map it to the genome to figure out where does it fit. We do that automatically in the pipeline for all of those reads. Once it's aligned, the next step is to start screening all those regions vertically, looking for difference between reference genome and those patient DNA segments. And the moment we detect a difference, we pick that as a potential mutation. And then we measure how many evidence supporting the reference genome versus the alternative allele. In this case, for example, let's assume there is 100 reads, NGS reads, covering that region. If the normal allele is supported by 55, then the allele frequency here is 55% and 45% for the variant allele. The reason I'm mentioning this is for somatic mutation, usually it's much lower, 20%, less than 30%. Anything above that is potentially a germline mutation that require a skin biopsy to confirm it. And if we are not dealing with the patients through this approach, the other is with the family history or the clinical history of multiple cancers or young age than the usual, or a strong family history, then we can go directly into the comprehensive germline testing. And the moment we detect a deleterious or confirm it in the patients, then this warrants a follow-up with the surveillance, offering counseling for the patient and the family, and doing a cascade or segregation study in the family members, and assess the related donors for the familial variants. And so in summary, we discussed when to suspect germline components in hematological malignancies. It's more common than we think, up to 1 in 6. Family history is not always present. It's usually in less than 45%. We discuss NGS as the most important method to use in this situation, mostly because of the large number of genes to be investigated. Skin biopsy, of course, is the gold standard here. And the AMP and CAP guidelines is what we use to systematically interpret and classify variants of unknown significance. And with that, I reached the end of my talk. Thank you very much for listening.